All right, the recording is started.
All right, everyone, welcome. I'm Amber Johnson. I'm the Vice President of the Board of Health for Boulder County. I'm going to call this meeting to order. This is Boulder County Board of Health regular meeting. It's March 9th, 2026 at 5:34 p.m. And I will invite my fellow board members to introduce themselves.
Stephen Yoon.
Landry Fagan, board member.
And with that, we have a quorum present. This meeting will be posted on the Board of Health website, and the call-in information and the address were shared publicly for participation. We're going to move on to the agenda item number 1, which is public comment. Are there any public comments for tonight?
No, we didn't receive any public comments for tonight's meeting.
Moving on, agenda item 2, we're going to approve the prior month's meeting minutes. I make a motion to approve the meeting minutes from the regular Board of Health meeting on February 9th, 2026.
I second the motion.
All in favor?
Aye.
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 That's approved. Item number 3, we have a state policy update. Sure.
No, we have a measles response, but that's okay. There.
That threw me off a little.
Your eyes got real big.
We will have it. Yeah, so I think you all know that there has been some measles activity in this area of the state. Yeah, understatement of the year. And we just wanted to provide an update on what's happening in that space, how broad it is, our response and our collaboration, because it is a multi-jurisdictional response. And I will turn it over to Stephanie Farron, our Division Manager for Communicable Disease and Emergency Management.
Thank you. Hi, everyone. I'm going to sit right back down again. Do we know if Nicole is on?
Can you see, Dahlia, if Nicole has joined us?
Nicole's on.
Oh,
Okay,
awesome.
all right,
Thank
Chris,
you.
I think I'm going to turn it over to you to start with. And then we also have Nicole Comstock from CPH.
Great, okay. We can go to the next slide, please.
Yeah,
Yeah,
so we're
Nicole,
planning to
yeah.
do kind of a response overview, our current situation, what we've been doing during this response, and then what we expect kind of the next maybe week or two to look like, or hopefully not look like.
So we're gonna have Nicole Comstock from CDPHE present first. We invited Nicole because this has been a multi-jurisdictional issue that has impacted other counties, including primarily Broomfield and Adams. And so we wanted Nicole to share that broader overview and also give you some background on the national picture and everything else. So I hope our slides will work. So, they got formatted
No,
to,
I just looked. I think they're fine.
okay.
Can you go to the next slide, Dahlia?
And Nicole, you're a presenter. I mean, if you want to present on your own, you can take over. I made you a presenter.
Okay, can you all hear me?
Yes.
Yeah, welcome, Nicole.
Okay, I don't, oh,
You
there
got
we
it.
go. I see right click, sorry. Okay. Well, thanks everyone. Thank you very much for having me come to your meeting today. It's an honor. And I just want to call out to how amazing it's been working with Boulder County Public Health and the metro area health departments in this response. It's been a lot of great collaboration. So we will start with just the national picture. So we are a little more than 2 months into 2026, and we've already had over 1,200 measles cases reported nationally. For reference, in all of 2025, there were 2,281 reported nationally. So we are almost halfway or more than halfway to the case count that was seen nationally last year. So it doesn't bode well for measles in the US this year. We are expecting a busy year. There are a few hotspots around the country, including Utah. They had a large outbreak that started in the summer of 2025 and is continuing. So back when the outbreak started last summer to now, they've had 358 cases, primarily in southwestern Utah, but now that outbreak is kind of burning out and things are starting, their case counts are starting to move further north in Utah. Arizona has had 56 cases so far in 2026, and primarily in their northwestern corner. So that southwestern Utah, northwestern Arizona is where kind of the epicenter of the outbreak there. South Carolina has had nearly 1,000 cases since their outbreak started last July, and that is primarily in northern part of South Carolina. And then Florida has had 124 cases in 2026 as of February 28th. And most of those cases are associated with a university outbreak, Ave Maria University, located in southern Florida and Collier County. So just to demonstrate what this year is looking like nationally, you can see up here around right after the holidays, a very large increase in cases. That was primarily driven by the South Carolina outbreak, but it is starting to dwarf what we saw even during the peak of last year. So just as a refresher, last year in Colorado, we had 36 measles cases reported statewide that occurred in 10 different counties. Of those 36 cases, 24 were unvaccinated. We had 5 of the 36 cases were hospitalized, unfortunately no deaths. And last year, if you looked at our cases, some of the demographic features, we had 21 adult cases and 15 children. And we'll talk about in a minute, so far this year in 2026, all of our cases have been children under the age of 18. For comparison, between 2015 and 2024, we averaged less than 1 case per year of measles in Colorado. The range was 0 to 2, but there are plenty of years there we had no cases reported. So this has definitely been a steep learning curve, and everyone is getting up to speed around the state on how to respond to measles. Our outbreak last year, if you look at the chart here, we had a couple of more contained outbreaks. In May and June, we had an outbreak that occurred due to a infectious traveler from another state who was in a European country, was on the plane while he was ill, and then exposed people on the plane and Denver International Airport. So that's the green colored there. And then last August, we had an outbreak in Mesa County that was caused by person-to-person spread. Throughout the year last year, we did have a couple of cases who were exposed internationally, but came back to Colorado when they were diagnosed and got sick. And we had a couple of cases that had unknown exposures. So looking at this year, now that we're about a little over 2 months in, we've had 8 cases reported so far in Colorado in 2026. This is data as of actually today. We haven't had any new cases reported since last week. So far our cases, so the 8 cases reported in Colorado were all unvaccinated. No one has been hospitalized. All our cases have survived, and all 8 cases are within the 5 to 17-year-old age group. And this is our epi curve for our cases so far in 2026. We have one outlier here that back in the end of January, we had a case who was from Colorado, but was exposed while traveling within the country and diagnosed in another state. There was no exposures here in Colorado, fortunately. And then the blue bars represent our recent outbreak of cases associated with some schools in Broomfield, which we'll talk about here in a second. We did have one other case that isn't reflected on this epi curve, and that was a case you might have heard about in the media. It was a Florida resident who traveled to Colorado while infectious and had some church exposures in the Denver metro area. We count cases by the state that they reside in, so that was Florida's case to count, even though we did a fair amount of disease control and contact tracing here in Colorado. But that case is not reflected on this epi curve because it's a Florida case. So as of March 9th, we've had 7 cases in the Broomfield County outbreak. 1 Broomfield County case, 1 Weld, and then 5 who reside in Adams County. 5 cases are in students who attended Broomfield High School, and 2 are in students who attend Broomfield Heights Middle School. We are posting where cases could have exposed others. So when these cases were infectious and contagious, we do post on our website where they spent time where others could have been exposed. And we do keep that running list going. We add to it as we learn about new exposures. Some of these 7 cases are household contacts to each other. So we have a couple of cases that are linked that could be household transmission to each other. Their rash onset dates are pretty tightly clustered between February 19th and February 28th. And what we're not clear on is if there's a common exposure among all these cases. So because these cases all occur within one incubation period, it's possible they all had a similar exposure and then all got sick within around a pretty tight time frame. Or especially some of the household contacts, they could have been transmission between those household contacts. So we don't know for sure. We're actually over 3,700 known contacts of these cases who are being contacted and assessed by public health. And that sometimes includes monitoring for symptoms based on that person's risk. So if you're a contact and you're unvaccinated and you had exposure to a case, public health will often monitor that person for symptoms through the 21 days after their last known exposure. We are doing a fair amount of mHealth or mobile health text notifications to contacts when we have phone numbers or cell phone numbers, trying to alert people that they may have been exposed and to fill out a survey so we can assess what their risk might be. About 80 non-immune students and staff, and these are primarily students, have been excluded from the affected schools. And then we have activated our wastewater emergency wastewater surveillance sites, which we'll talk about in a second. In terms of how we're learning about cases, most of them are reported through traditional methods, laboratories reporting cases to us, healthcare providers calling in suspected cases. We have found some cases by the contact tracing that we're performing. And then we are setting up wastewater surveillance, and I'll show you what that looks like here. We have short-term emergency wastewater sites set up. So in this map, the sites that are the kind of the boundaries that are shaded blue are our normal Sentinel sites. And we have worked with other wastewater utilities outlined in kind of the black borders there to have them set up surveillance for measles, and that started last week. And so we do have enhanced surveillance going on our wastewater to try to see if that will help us look for any geographic spread. And that's it for me.
Thank you so much, Nicole. Are there any questions? Any questions for Nicole?
So we're still within the incubation period of this outbreak, right? So of the people who are quarantining, what is the end date for this outbreak?
March 20th for the last known exposure date, public exposure date of February 27th or March, or yeah. Although we have people who have been infectious past that. So household contacts, it could go a little longer,
yeah,
for example, but we're like smack in the middle of the average incubation period right now. So the next week is going to be critical, and then, yeah, until March 20th.
In addition to like assessing vaccination status, how are we assessing immunity? Like, we know that MMR vaccines last forever.
They do. We consider them lifelong immunity. We can also assess immunity through titers for people who've had a vaccine or disease but don't have their records. There can be a blood test to determine whether or not they have immunity. And that's really the only things we go by to assess immunity, either history of vaccine or history of prior disease.
And does Broomfield have like lower vaccination rates among school-aged children than average?
No. Their vaccination rates are 97% in each of the schools. So high, it's like 95 is considered immunity. So they have really good rates, but I think, and I don't know, Nicole, what you think, I think it's prolonged exposure in the school. I think we counted a total of 7 or 8 days for Broomfield High and fewer for the middle school. And so it was just multiple days of an infectious person in that same place. So getting to more people.
Even between classrooms. And that's, yeah, we haven't seen any cases of the staff yet, but that vaccination rate is just the students.
Yeah.
Thank you so much, Nicole.
Thank you, Nicole. Please give our best to everybody over at CDPHE. We appreciate you all so much.
Yeah,
Yeah,
so grateful for all the coordination and everything.
Yeah, thank you again for having me.
Of course. Again, hi, everyone. Chris Campbell, the emergency manager, Boulder County Public Health. And we just, Carol and I are going to discuss just a bit more how how we've organized locally as an agency, some of the impacts we're seeing. So I wanted to share that with the community, with the board. We have, interestingly, we've definitely done some work on this. Anticipate if we might see a measles outbreak. And in fact, the most recent one, we had a tabletop exercise and maybe anticipated some of the things we've seen in this response, like choir concerts in schools, potential impacts to our education, like CU, which potentially could have seen and ruled out recently. So, but what's been incredible about that is in those discussions, these scenario-based exercises, we've really brought partners to the table, like the school districts, early childhood partners, healthcare partners. And so as this unfolded, as this outbreak unfolded, this work unfolded, we were really well coordinated and connected. So, but I will say, and it's good to understand that, you see our incredible state partners. They've had tens, dozens of staff working on this, more. It's gotten really complicated because it's really cross-jurisdictional. And we've had Broomfield, Boulder County, Arapahoe County, Adams County impacted. You saw all of them, Weld County, go on in this metro region, all with just a role to play to follow up, to communicate with the community, to follow up with potential contacts. So what we did identify is really that need for cross-jurisdictional coordination. And at the beginning of, as things start to unfold, that's a little challenging, and we worked hard to build those structures. We have a policy group that's working with Lexi, really cross those jurisdictions to look at broader policy decisions like public health orders. We have incredible work going on joint information system with the state health department and other local health departments to get communications out to the community. So, I think we've anticipated that need and written plans around that. We've activated our incident management team to support this. And this has been going on really in earnest since Thursday, February 26th. So we have been working pretty much nonstop since then. And Carol's going to give you a little idea of how to quantify that time and what it means for the agency. So really resource intensive, even if.
And this has been an agency in a county that hasn't seen any cases yet.
Exactly. I will say, I think we have a great relationship with Boulder Valley School District, and one thing we have learned from past responses, like a TB response we had actually with St. Mary Valley School District. It's really helpful to have one point of contact when you're working with the school district, and we've worked to play that role, and staff has done an incredible job, Steph Farron, in that. So
we are also fortunate to have Stephanie with us, who's a former head of nursing at BVST. Is that your title?
Yeah, I was Director of Health Services during COVID.
Director of Health Services.
yeah, so it's been a helpful point of contact and really, helped the schools. They've navigated this. Yeah, and I think since we've built all this, we have our incident management team working. We've supported and Carol really detailed the work of the epidemiology group and others. I think we're in a good place now as an agency. We're seeing things stabilize, and you've heard some of the kind of where we're at with the response and the epi curve and things. So, I think we're in a good place as an agency. It's just as we continue to bring senior level staff in, communication staff, other staff, that it is a strain on resources. So we're just working through it.
Next slide.
Are Boulder County providers notified in a special way from the?
Yeah.
They are.
No, yeah, great question. And we do have a state HON system similar to the CDC National HON system for local providers. So there have been 2 HONs, I think, since this started out direct to every
Stand for Carol?
Health Alert Network.
Yeah.
It's the notification system. So every registered healthcare provider through DORA, the Department of Regulatory Affairs, that's the contact list. So if you have a license to practice in Colorado, you get notified through that email address or text or whatever you prefer to be notified by. So yeah, those HONs have gone out. And for us, I think Lexi already mentioned how great it is that we have Stephanie's experience working with BBSD and having all those connections to have that coordination with the school districts. And then we're also super grateful for CDPHE's coordination because it does involve so many LPHAs across the region. And so we've been having daily calls. And we had already been having daily calls because of that traveler that Nicole mentioned, who was like an out-of-state case. It wasn't counted in Colorado, but that person had lots of exposures in Colorado that we were already following up on and convening on. And then it just folded right into this additional response when we got that notification on February 26th. And so for us, like, yeah, we haven't had any cases, but we do have students who attend the impacted high school. And we also had students from other middle schools, high school and the middle school. We have students who went to Broomfield High for events. There was a choir event and a theater showcase. And so we have had kiddos from Monarch and Manhattan Middle School and other middle schools who were exposed and susceptible, meaning they didn't have history of MMR vaccination. And so we've had a total of 78, although they keep trickling in. After this slide was already done, I saw we had another 2 cases with healthcare exposures, although those exposures occurred, you know, like a little bit ago, but we're still getting those. And so we have 14 people who we're actively monitoring, meaning that they're in quarantine, and we do daily symptom monitoring with them to find out if they're developing any symptoms. And of those 14, 10 of them are school related and 4 of them healthcare. And I guess that is going up to 6 healthcare after tonight when we get them counted. We've done a lot of partner outreach. The ECEs, we have a really strong ECE program that I'm sure you've seen, and you can see their calls that are held with ECE partners are on our YouTube channel as well. And
Early childhood education.
yes, early childhood education or child care partners. And I'm pretty sure there's one recorded about measles done not too long ago. But the state will also be providing more education for them as well, and we'll promote that. We did outreach to our private schools to notify them, since we've been working primarily with the districts. So with St. Vrain, we've notified early on as well, but we also reached out to those private schools that aren't part of the districts. And our healthcare partners, we have CIDR, or the Community Infectious Disease Emergency Response Team, that has been convening since Ebola back in 2014 and 15. That was a huge response that healthcare had to do a huge lift to coordinate and change practices and adapt to be able to monitor and identify if anyone had been to the Ebola hot zone. And so after that very large response, where in the state we had to identify a location for if we had a case, where would they go? So we had a regional, like, this is going to be where the viral hemorrhagic fever goes. It was a lot of work. And after that, we didn't want that to just gather dust on the shelf. So we created the CIDR team and kept together our 5 hospitals and lots of healthcare partners. Like now we have urgent care partners in that group, emergency response. We have the ambulance services are involved. Like we have all the partners and we convene. And since Ebola, up until COVID, we used to meet once or twice a year. And we did a health vulnerability assessment back then and identified that the biggest risk would be respiratory aerosolized transmissible diseases such as MERS and SARS and whatnot. And so it's a theme that we kind of prepare pretty well. I think we should put that feather in our cap that we've prepared well and thought ahead and kept the partners engaged. And during COVID with that CIDR team, we were meeting daily, weekly sometimes. And we were thankful to see that cadence go down. And we have sent communications out to them and we'll be meeting with them this week. Did you have a question?
Just to mention real quick that private schools sometimes have lower vaccination rates than the public schools. And also to mention that since COVID, we have seen lower rates of vaccination among young children than historically. So the ECEs and the private schools are of particular concern.
Silver lining is today our immunization clinic out in Longmont did 9 MMRs. So there is some uptake. And I know when I went to Target the other day and I just asked the CVS pharmacist, they said they've been really busy doing MMRs as well. So that is good that the word is out and folks are out there getting protected. And then the comms team has been awesome, supporting this response. And there's been a ton of response and outreach materials produced, signage, fact sheets, great social media updates, and internal staff updates, and just a lot of work. And so we tried to summarize. We have a rough estimate for how many hours staff have been working on this from that evening of February 26th through yesterday. So those first like about 10 days. It breaks down, it's been like it's 21 different people at least. I don't think everyone's filled out the time reporting sheet. But of the folks we have in there already with their time reported, it's as if we have 8 people working full-time 7 days a week. And that's been for the past 10 days. So it's been a huge resource lift, I think, for our staff to work on this response. And then I just have one more slide to wrap us up. So we're still monitoring those 14 folks. We are not out of the woods yet at all. As we talked about earlier, we still have that incubation period through March 20th. And we like to count 2 incubation periods when it comes to epi and different diseases, because we might miss one. Like I hope we won't, because the schools have really good like tracking of who goes there and things. So I'm hoping that we will be out of the woods by March 20th, but we're still in the thick of it. And I do think these collective efforts across the state, across all partners, are gonna greatly mitigate those impacts, especially if you see that the last public exposure was February 27th, even though the last rash onset of an infectious case was February 28th. So that's like a little sign that, okay, we might have mitigated future exposures. And let's see, additional things we're going to be doing is engaging surge capacity for ongoing hands-on training. We've already done tapped some surge staff to help with this effort. We've been training additional nurses to do measles specimen collection and pee and urine out in the field, because sometimes it's better to just go get specimens collected in a household, for example, instead of having someone go and expose a healthcare facility, especially if they're not sick enough to seek healthcare. If they need healthcare, of course, we want them to go to healthcare. And then we'll be hosting a CIDR partner call this week. We've sent email updates and provided communication materials and like signage for the front doors so people don't walk in if they've been exposed, because that's been an issue. We know of at least 4 situations where people were exposed and went into the waiting room and sat and waited and then said, oh, I have a cough and I was exposed to measles. And then everybody freaks out. So we're trying to avoid that with signage and a lot of communications that we've sent out. And then there's those learning opportunities that we're going to connect our partners to. And of course, as we always do, which is so great with Chris's team, is engaging in those after action reviews so that we can do it better and better next time.
Yeah, like I mentioned, we've already used some lessons learned from recent responses to really help us be a little more efficient and effective. So it's been great.
Do staff just volunteer to be on the team, or are they volunteered or not?
It depends.
Volunteered?
Like Eleanor,
Yeah.
I forget what it was. Like you saw a spreadsheet and you're like, oh, I think this one little tiny field. And I'm like, you're gonna be on our. Because you're good with data and things like that. But we like one of our goals for this year is to build out our surge team, and now we're kind of just doing it, building that plane while we're flying. And now that we have this active response, even though we're not in the full tilt boogie response phase anymore, it's nice to have a real activation that people can practice on. So when we do like our mop up and stuff, folks can be working on actual data and information. So we are building up that training right now.
And do the supervisors have to give okay? Are there like mission critical staff that cannot be assigned?
Yep, in fact, we had a couple of staff that were going to be responding, and we said, sorry, they've got some other priorities right now, but maybe next week.
But we have had, I would say, both folks volunteer, say, hey, I've done this in the past, I'd be happy. And then some folks that we've just asked, to please come and help us.
But that, creating that search team was part of our strategy after we did the staffing step down, was to make sure that we knew who in the agency had skills in specific areas. We still have some work to do on that search plan, but, this was a great test case. Who has a question?
I just wanna add in, I'm sorry, I didn't see the chat function. It's actually in everyone's job description that they have to, that they may be reassigned during emergencies. So it's something that is embedded in everyone's job.
Does it include Board of Health?
Oh, yeah.
We'll make sure you get the survey. Yeah.
Sure. Are you volunteering, Steve?
You all heard it, right?
I will also say that the directors of Broomfield and Adams and Boulder have been meeting along with a broader leadership team on policy discussions. I think we're meeting at a cadence of 3 times a week to make sure that we are doing things consistently with each other. We don't want to have jurisdictions that are being more stringent or less stringent than others. We want to have a consistency in practice. And it also helps us to identify where we have resources we can share, even if it's, a form or whatever. It helps us stay on track in terms of aligning our messaging to the public. And we definitely work with CDPHE, and the LPHAs are leading this part of the process. So.
I'll say as a Boulder County, resident and a parent and a healthcare provider, I'm very appreciative of the level of readiness that you already had and how proactive you're being without even a case in our county. It's impressive what the team has done and love the work.
Amazing team.
Thank you.
Thank you so much.
Appreciate the time.
Now you've got to go to another emergency.
Yeah, well, there's a potential power shut off, so. So never know moment, Boulder County.
That's right. Well, it's windy. Thank you all. Thank you.
Thanks.
All right, moving on. Item number 4, we have an overdose trends and opioid evaluation highlights.
Yeah, so just as a quick intro, Boulder County, like many, many, many counties across the country, has had and continues to have challenges with overdoses, largely related to fentanyl and more recently meth. We, being the innovative public health department that we are, we have developed some really robust responses to this. We wanted to share with you all some of the trends, what our programs are doing, and a little bit about kind of the evaluations of the program. So please take it, Stephanie.
Thank you.
Again, it's been a big week.
It's been a big week.
Already.
Is it all right, Patrick, if we take over presenting? Or me, I guess?
Yeah, you can, if you hit the take control button at the top, you'll be able to advance the slides.
I like take control buttons. All right, thank you. Well, you have already, but I'm going to quickly introduce other members of the agency that are working on this, both from a prevention and a harm reduction approach. Georgia is our harm reduction manager. Somebody put these in alphabetical order, which was very nice. Thank you. Allison is our community substance abuse prevention program manager. Julia is our youth program, naloxone program. I'm going to let you talk about it. And Delilah is a youth advisor. Is that correct? So everybody's going to come up here and share with you today. So our outline is kind of a general overall opioid response in Boulder County. And I've asked Carol to stay because Carol was in this program not when it was first started, because that would have been way too long ago.
37 years ago.
So, but
Only 26.
yeah, more recently, but she's going to share a little bit of kind of how we got started in some of the work that we're doing now, the current efforts, which is the youth opioid overdose prevention, or you say youth or you? You, okay, good. And like I said, the Works Harm Reduction Program and SUAG, which is also under Allison in Community Health. I'll talk briefly about some of the funding that we have, some trends, and then what everybody's going to be doing over the next year. So this is a slide that we found from a number of, actually Allison found from a number of years ago, that I believe Carol had probably put together. And it does outline a little bit of when some of these first programs started. So I'll let you talk to that for a minute.
So I started with Boulder County Public Health in 2007 with the Works program and our HIV prevention program. And then you can see here, 2010 is the beginning of the year chronology there. And prior to that too, since 2007 up to then, we had about that 150 number of participants. And then we started to see an increase in overdose reports. And as you can see, we started to see an increase in the number of people seeking syringe access services through the Works program over time. And we started working on naloxone. I don't know if you know the RIHELP program, the regional environmental health leadership thing. You're part of it also. And that program it's a leadership program, and you have to do a project. And my project was naloxone. And I graduated in the 2011 cohort, but it took us a little bit to get naloxone rolling. There was, I think, some pushback for naloxone, but back in 2013 is when we first started, and we were able to get legislation passed and all these things for standing orders, and we got naloxone out. And now I feel like naloxone is widely available, so I'm really grateful for that. And then you can see there how those numbers went up. I think it's like 12-fold. It increased from 2010 until 2017. And I think since then it's kind of leveled out. In Georgia, I don't know, I think, are you at about 1,700 participants per year?
But last year it was about 1,200, so we've come down.
So that's
But
good.
a lot of encounters, that those are individuals. and
Yes, these are the
encounters
individuals. You just see
really
people
high.
multiple. That's awesome. But that's great to know that it's stabilized, and then that it's gone down since then, the number of participants. Because when you have participants in the Works program, they're more likely to get engaged into substance use treatment and other services. So I'm glad that we're seeing that decline after the peak of that opioid epidemic, really, which also impacted the Works program. And I think the last thing on there is the 2016 is when we first started doing the substance use advisory group. Back then it was called opioid advisory group, but now it's substance use advisory group. When we did a landscape analysis and lots of work to get this rolling. And I think that's it for me.
Okay.
Yeah, I'm around there.
I actually started with BVSD in 2013, and I remember being a part of the SUAG when that started, and the Healthy Futures Coalition as well. So the partnership has been going really strong for a long time as well. So a little bit more recent, we skipped a little bit of time there, but in 2021, that's when BVSD included their stock naloxone policy. So they have naloxone stock throughout the schools, and students are allowed to carry naloxone, and they're not harassed at all. Usually. And then the community naloxone distribution and training plan really started and got going in 2021 as well. In 2022, the Boulder County Regional Opioid Council was established. The Fentanyl Response Work Group was established, and we just renamed it this year to the Overdose Response and Planning Work Group. Chris and his team worked on an emergency response plan for drug outbreaks, and the youth program was began at that time as well. And I'm going to turn it over to Julia and the live.
I'm going to briefly talk about what the youth program does. So one of the main things we do is we provide interactive Narcan and harm reduction trainings for youth. We have a photo at the bottom right corner of the screen. It's a nose demo that we like to give youth for them to practice administering Narcan. It's super fun. Our trainings are very youth friendly and they're evidence informed and they're trainings designed by youth. And as a youth advisor, I get to help develop the program as well as deliver the trainings. We offer our services in both English and Spanish, and we work throughout the entire county as well as other our rural communities. We also do outreach at youth serving community events where we share Narcan information as well as other resources. And lastly, we support organizations that work with youth by helping them access Narcan and other resources for the youth that they serve.
So Delilah talked about the outreach that we do, and that's at various community events that serve youth. So it could be like a Pride event or Take Back the Night at Front Range. Those are just two examples. And in 2025, we reached 536 youth through these events and 994 people total. So that includes adults as well. And through our trainings and this outreach, we distributed 609 Narcan kits, which is pretty awesome. And through our trainings in 2025, we trained 236 youth on how to administer Narcan and what harm reduction is and things like that. You can see the photo that somehow shifted and is covering that word. It's youth playing the memory game. And so they like flip over and it's images and the steps on how to administer Narcan so that it's a way to interact with the information so that people can remember it better. And after our trainings, all youth complete an anonymous survey, and 90% of youth report an increase in confidence that they could administer Narcan if needed. And 92% report that the training was taught in a way that was easy to understand. And that's really important to us as we try to make these trainings as youth-friendly as possible.
Yeah, and we pulled some quotes from some surveys that we give out. And so the quotes down below are coming specifically from youth that we've trained. And I can read those out loud. The first one says, I like that we are able to play an interactive game involving this training because it helps the information stick in my head. Another one was, I plan to use these skills in my own life and educate my peers about it. And the last one we have up there says, learning step by step what to do if someone overdoses helps my anxiety so much.
Mm-hmm.
What age range is youth?
Youth goes all the way up to 26.
Oh.
Yeah, so youth and young adults.
So what does it like? What's the lower limit of this?
I mean, we don't do this education for elementary school students because we just that's not our background. That's not what we're ready to do. So usually starting in like middle school. Mm-hmm.
Yours now.
You guys can I see? Hey, so thank you, youth. It's an amazing program working today. Amazing youth. They do stuff that we can't do ourselves, folks. So I'm going to talk about the harm reduction service, which mainly reaches adults. Rarely do we have someone under 18, but have you guys heard of the harm reduction program in Boulder County? Yes. Okay, good. Third oldest program in the country. And I just want to give kudos to Carol, who made my job very easy when I came in because it was so well established and, it made my life a lot easier when I came in. So we are the only full service harm reduction program in the county. Other people are doing like Narcan training and maybe distributing fentanyl test strips. But you'll see basically all of these activities that we do, we're the only full service one. So we have syringe access, so that's fixed site syringe access where we distribute syringes in Boulder at BCAP, Boulder County AIDS Project, Longmont at the hub, and that's where our staff work directly, and Louisville at Clitica. And we also have the only full service vending machine at the Lafayette hub. So it's pretty exciting, being used, really exciting.
The only one in the state, right?
The only one in the state that's full service, yes. We do street outreach to the unhoused in Boulder and Longmont and other places where we can get in. We do a range of STI testing, which is great. We've really significantly expanded that testing in the last couple of years. Jail testing and education. We've got a great relationship with the jail, weekly in the jail. Community presentations. And we do community events as well. We're often hanging out with these guys at different, Cinco de Mayo and stuff like that. Bilingual, we have a bilingual educator we've translated a lot of stuff and transcreated, which means that we adapt it to the community. A lot of naloxone distribution to community partners. Syringe disposal, we have it in various sites, and we do syringe litter walks. We see very few in the community, which means people are using our containers, and that's working really well. And we have food passes and shower vouchers, which is, I think we're seeing we're not sure exactly why we're seeing a decrease, but a lot of people are getting into treatment and recovery, and having all these extra services is helping them go get a job, take the bus to Denver, stuff like that. So very exciting. Do I press the next one? And then just a few boring numbers, but it's pretty exciting at the same time. Last year in 2025, we had 9,324 encounters. So even though we had about
it was almost
1,300 encounters, okay, and then which is people coming back multiple times, and we are seeing a lot of people coming back not for syringes or tobacco, smoking supplies, but all the other stuff. We also have a lot more food that we offer. We offer clothing, so it's great to see. We work closely with partners that help take people into treatment, which early on we didn't really have. 31,796 syringes. You see a lot of pipes, fentanyl test strips, a lot of naloxone, 5,505, 84 overdoses reversed that are reported directly to us, but a lot of people don't report to us. So we can say at least we saved 84 lives, but we think it's a lot more.
That's amazing.
Yeah.
I just want to pause on that. That's incredible.
Oh yeah. Yeah. It's pretty amazing, the stories we hear from people. And yeah, that's why we do the work that we do. 60 trainings, 605 people trained. We get funding to do like 3 trainings a year, actually 6 of 2 different types, but we do 60 because the demand has been so great. A ton of referrals, 925 referrals. A lot of them warm handles to, referrals to treatment, inpatient treatment, outpatient treatment. We have a great relationship with Longmont Lee. They're able to actually come take people in a car. We don't have a car. We're not able to do that, to all these treatment places. We have an amazing relationship with all these places, clinics. We work closely with the downstairs, human services, food stamps, workforce, tons of recovery cafe, other recovery services. So tons of great relationships with all these people. And we do syringe litter walks. We find very little syringe litter. And that's it, I think. Yes. Any questions about our program? Please come visit us.
Could you talk a little bit about the naloxone? Because I do not.
Yeah, so the state still has had to make some restrictions on naloxone. We still get it as a program, but a lot of the community programs we're not able to get it anymore. So we've been collecting expired Narcan. We've got permission through legislation like 2 years ago to redistribute expired Narcan. So the university gave us tons of Narcan. If we didn't have that, I don't know what we would do, but we do distribute it a lot, and it's just become so normalized. But there is a question about what's going to happen at that state level, unfortunately.
So I'm going to talk to you a little bit about the Substance Use Advisory Group, the SUAG or SWAG. As Carol mentioned earlier, it was started around 2016. Our primary prevention coalition, the Healthy Futures Coalition, was a place where folks were already gathering to talk about these issues, and decided to start a work group that was at the time called the Opioid Advisory Group, that has since grown up and now is its own separate coalition. And some of the things that the Substance Use Advisory Group does is engage in shared leadership and collective action. So we have a steering committee of folks from the community who partner with staff in terms of thinking about our agendas and resources that we bring to the meetings. Also mobilize and coordinate existing resources. So that's one of the really big things that SUAG does, is bringing folks together so that we are coordinating efforts, we're not duplicating, we are bringing different sectors together. So there's folks from prevention, treatment, harm reduction, recovery, folks who are in community-based organizations, folks with lived experience. We have law enforcement presence, educational institutions. So all kinds of different folks coming together. We try to make it the DA's office. Yeah. All so many folks that are coming together to think about a comprehensive response. We try to make it really easy for folks to come. So we do either fully virtual or hybrid meetings. We always have the hybrid option, which is really helpful for folks, especially for folks who are providing services during that time. So they can sort of step away for a little bit or may still be with clients, but then be able to also attend our meetings. One of the key pieces that I do want to mention is a big goal of SWAG is to elevate the voices of people with lived experience. So often I will have stories of recovery, folks sharing at the meetings, where folks are talking from their own experience about what it was like for them to use a lot of the services with folks around the table, and really bring that perspective to the group. Another place where the voices are really important is in the policy process. We have a policy work group where we have folks who are giving feedback and providing information on potential legislation. And so having the voices of folks who have experienced that, folks who are in the field, is really valuable to that process. And then these are just a few quotes from a survey we did. We had an open-ended option and just some really nice compliments from some folks talking about the value of the space of bringing folks together. And it's been continues to be a really important space. We've gotten some statewide recognition, and always a place where is an important role for the county to play of that convener, of bringing folks together and really making it so that the community can take the lead, but we're creating the space for that to happen and providing those resources.
To the partnership, I think that Lexi, you were kind of alluding to, these are just some of the partners that work with these programs, and really just a small number of them here, but it really does highlight, I think, that a big part of the success of these programs, both long-term and even more recently, has been through these partnerships. There is a lot of trust between the community and SUAG and harm reduction and youth. And there is a lot of trust, from us going back into these other agencies that we work with. The Drug Task Force, through the Sheriff's Office, has someone who participates in our work groups as well. And there is a lot of back and forth sharing. If harm reduction folks are hearing stuff that's, happening in the streets, usually faster than anybody else is going to know, that information gets passed on to them so that they can kind of keep an eye out for it, and then vice versa as well. So these partnerships really do represent a huge factor in the success of these programs. A little bit about funding. We do have Boulder County Regional Opioid Settlement funding that's kind of managed or overseen through Regional Opioid Council. Boulder has a Regional Opioid Council. There's 4 goal areas. We fit into prevention and harm reduction primarily. There has been a mix of both direct and competitive funding for through the ROC. For a few years now, the harm reduction program has had direct funding, which has been really nice. It's been flat funding, but it has been secured. We anticipate that is going to become competitive funding next year. And SUAG and UP also have been awarded funds, but they're also been competitive. So we are going up against other folks in the community when we're trying to find that. The harm reduction program is fully funded by grants. The same with, so all of this work is really fully funded by grants. At the state level, the HIV prevention and testing grant, which is CHAP, which also funds a staff person and supplies for harm reduction. We're anticipating about a 15% reduction for next fiscal year. The harm reduction grant, we are hoping is going to stay flat. That just about fully funds to staff in the harm reduction program. Who the heck knows what's happening at the federal level? The overdose prevention OD2A funding is the grant fund that is currently funding our bilingual harm reduction educator and that outreach. And then you all are all funded through opioid funding right now. So that is competitive. I think, there might be a sprinkling of some general funds in there when we, things have gotten cut during the year and things like that. So to support keeping things going, but we really are primarily fully grant funded for this work. And I wrote down and forgot how much of the funding Boulder County expects through the ROC over the next 10, 12 years. Is it?
I'll say 32.
Does that sound right? It's a good amount. Yeah.
Years. But we continue to get new settlements coming in. I sit on the ROC. We've taken a very conservative approach. We want to make sure the money lasts, but we also know that the money is needed in the community now. So,
thank you. So these are just some trends over the last couple of years that this data comes from our coroner's office. This is age-related patterns over the last couple of years. Like I mentioned, the primary age range for fentanyl-related deaths is still 30 to 50. But one notable increase that we saw in 2024, and that continues, is this older age group, 60 to 69. And some of the thoughts that are behind that have been that these folks who are unhoused are using methamphetamine more often to stay awake overnight so that they're not robbed, hurt, things like that. And, luckily for us, adolescents and young adults do account for a smaller share. Also, primarily, I'm sure because of the work that's been done through your programs as well.
Stephanie, quick clarification. Yep. That graph is on fentanyl, but you said the 60 to 69 was among people.
It's fentanyl as well. Yeah. And this will show you a little bit more. I think this is also from the coroner's report, and you can see that polysubstance with methamphetamine, fentanyl and meth has increased almost 200% over the last, that was over a year. That was 24 to 25. And primarily it was showing up in older folks is what we were seeing. Maybe not primarily, but it was showing up in the older folks had the polysubstance use. So this data is all data that the now overdose response planning and response group looks at quarterly. And there was a report. It's kind of a strategic plan done for 22 to 24. We have just finalized our 26 to 28 plan, and methamphetamine has been included to be one of the priority areas that we look at moving forward.
So meth has been in our community for a while. We did not see people overdosing on it a lot until recently when we think it started getting mixed with the fentanyl. Technically, meth is not an opioid.
Right.
So there are conversations too in the ROC about whether it's appropriate to fund this. The fact that it's mixed, that it tends to create an overdose when it's mixed with fentanyl certainly argues in my mind that it would be included under the opioid litigation funds.
And as far as 2026, I don't know if you want to speak to this yourselves. You're more than welcome to.
Sure. I think as you've heard, there's a lot of great work happening. And so we're going to continue to train youth on Narcan administration, emphasizing training them as peer educators. So what Julia's team does is train youth to be trainers, going directly to community-based organizations so that there are young people who are connected to community organizations who are training their peers. Continue to facilitate the substance use advisory group. With the new opioid funding that will be coming out, we're going to work really closely with the community services team to make sure that all the folks in our community have the information about when that funding is coming, and information about applying, and all of that. And then continuing to focus our efforts on youth who have less access to Narcan. So Julie's been doing a lot of work in rural communities, making sure that the trainings are in Spanish, to make sure that all segments of the community are reached.
Thank you. And Georgia, I'll let you speak to the Harbor Nation as well.
We just want to make, with all the funding cuts and everything, we just want to maintain our core syringe access services. That's juggling the funding and having supply funding. That is critical for us. We've been doing that. Continuing to expand our bilingual services and really adapting or sort of responding to community needs. So that's pretty exciting. Still doing outreach. So we do street outreach as well as community outreach, including presentations. And the jail and alternative sentencing facility are pretty critical, really high-risk people going through the jail. And now the new facility is going to be an exciting opportunity. The testing has been amazing to have all the testing, all the different STI testing. And now we have confirmatory testing, which is really cutting down a lot of barriers to people getting what they need. And then, you know, looking at methamphetamine use and how that is on the rise, and, you know, how we're going to just make sure that we are not just focused on fentanyl, but we're really acknowledging and looking at all the other substances that are coming through that are novel and completely unpredictable. We are quite interested in drug checking. We don't have the funding for it, but that's one of the strategies.
Can you explain what drug checking is?
So they have these, we do have, you know, our little scripts that we can give people. That is a form of drug checking, but the highest level of the best practice is like these spectrometer things where people can come in and we can use a little sample. And I visited a few programs to see how they did it, and it's pretty cool. And yeah, so to give instant results within 15 minutes, so that people can make decisions, much better decisions about what they're using. So that's
one of the biggest problems, and y'all probably know this, but I'll say it, is that when people purchase drugs on the street, they don't know what's in it. Right. And so they get cut with all kinds of things. And so to be able to confirm that something that they bought is what they thought it was is an incredibly powerful strategy for reducing overdoses. That is one of those spaces of innovation that, you know, this work always goes through a process of political resistance, and then people start to see the benefits. Somebody begins to implement, people see the benefits, and then it becomes normalized, and everybody says, gosh, why didn't we do this sooner? So we're in that, we're not in the norming stage yet. We're in the form of norming. But I will also say that, you know, a lot of this work really grew out of innovative practices and culture in Boulder County Public Health. And they're not letting up. I mean, the work that Georgia's team has done with the Latino population was a completely new access pathway to a group of people who had been neglected for many, many years, and it has been very successful. Yeah. I will say that we have adopted tools that allow us to understand where hotspots are happening in close to real time. That allows us to really pinpoint where we're going to, you know, invest our resources that week or that month, and see what's happening. That is in collaboration with, you know, the sheriff's office. We have amazing relationships with our law enforcement, and then the SUAG is, you know, the state just holds it up as a paramount of excellence in this work. The inclusion of people with lived experience directly in doing the planning and the feedback has really set it apart as a program across the state. So,
and that quote on the last thing, that's my, you know, that quote that she had, I was like, that's my quote, where I said, this is my favorite meeting of the month, because that, I was like, that's what I said. It is my favorite meeting because it is the most amazing coming together of people. And there other places don't have this. We should be writing a book about it or something. Yeah, but it is really spectacular. It's really good. If you ever get time to attend a meeting. It's a pretty magical space where people come together and get things done and connect. Yeah, it's
Yeah,
really
I think, and that's a credit to the work that Carol team started of really making sure that was baked in from the beginning.
And Dira was there too, you know, I know she's on the call, but she was there at the founding as well.
Thank you. Any questions? Yes.
Is the population at risk, mostly unhoused?
Would you know?
No.
No, we've got a lot of people who, so about 54% of our population that we serve is, would say they're unhoused. We have a lot of people that just go to work and using substances and but they come in and they're responsible and they sort of found out about the program. So there are a number of people, yeah, like I would say nearly half are people who are not unhoused.
So the fatalities to the overdose, they're also evenly distributed among unhoused.
Unfortunately, the data on whether or not they're housed is not easy to get.
Yeah.
But when we look at the map of where they are and stuff, there are people, you know, in fancy houses overdosing as well.
Yeah.
And, you know, children of, you know, parents who are school children, you know, teenagers, it's affecting a lot of people, yeah. But a lot of with unhoused, it's, you know, people trying to stay warm, trying to stay awake at night and stuff like that. That's
Because they don't feel safe.
yeah, trying to, yeah, and then sleeping during the day and all that. Yeah, so that is a factor, is staying warm and staying alert, unfortunately. But it affects every, you know, like sorts of people.
Yeah.
Thanks.
Thank you so much.
You're welcome.
Yeah, Julia, please give our appreciation to.
She had to study for a test tomorrow.
Yeah, but it's great. Appreciated having her here. And congratulations to you all. I know that that was evaluated as part of the Regional Opioid Council, but the evaluations came back just really glowing and stellar. And I can send that report to the board to make sure that they have a copy of it. But congratulations on that.
Thank you. It was not public that we recognized, so we weren't sure if we should share, but you can do whatever you want. Dolly, I'm gonna let you take control again, if that's all right. Otherwise, I'm gonna turn this all off. Thank you, Carol. Thanks for everything.
Right, yeah.
Thanks, Stephanie.
Yes, you're welcome.
Last.
Item number 5, our legislative update.
Tessa.
Hello, my name is Tessa Hale, and I am the policy analyst at Boulder County Public Health. I use she, her pronouns. I'm sorry I can't be there with you in person, but don't want to expose anybody to anything. So I am remote tonight, and if you have any questions, feel free to raise your hand at any point. And I'm going to dive in with a couple of pieces of legislation that we've been really active on. The first one, which is just so important as we had our first presentation tonight on the measles outbreak, which is ensuring immunization access for Coloradans. And as you recall, this is really about making sure that Colorado follows science-based standards on immunization recommendations, increasing access for folks. And we provided some written testimony. Carol Helwig, who you heard from earlier, did an amazing job of writing some important rationale for why it's so important that we support immunization access right now. And this is moving forward. It's had its second reading in the House, so it's moved out of the Senate into the House. It had its second reading, and it's just sort of getting scheduled for the next, the next reading, and it's not hung up for any reason that there's any concern over it not moving forward, just kind of a general scheduling things going on with it. So we're pleased to see that moving forward.
Tessa, can you just remind me, is this the one that's tied to the insurance coverage?
No, this is
Okay.
different.
That's what I thought. Yeah.
And the next one, this is the one, so these are the two we've been really active on because they really impact public health and our priorities the most, is the Expanding Colorado Cottage Foods Act. So as a reminder, this is also known as the Tamale Act. And what this does is it allows for temperature controlled foods to be sold by an individual that's made in their home kitchen, that is unlicensed, and that does not have any kind of inspection or regulation around it. There was a hearing, and it was very busy with people both for and against it. And there were some amendments made in real time. So the way the bill looks now is that a cottage food vendor could make up to 5 different kinds of one type of food. So it could be one type of pizza, one type of tamale, 5 different variations within that one kind. The other thing that was changed is that they had removed a revenue cap. So it was totally unlimited as to how much revenue someone could generate. The cap is now $150,000 annually. We had Shauna Johnson, our consumer protection coordinator, who did an analysis of how much time we currently spend on fielding questions related to the current Cottage Food Act, supporting people and doing some T&A, as well as an analysis of how much an outbreak costs, which we were able to turn into testimony. And Shauna was able to really provide like a unique lens as compared to anyone else who is testifying in opposition to this bill about what the real impact is for local public health agencies. So that was really effective. Unfortunately, it did not sway the House Ag Committee, and they voted in favor of moving this forward. So, we're continuing to provide information to legislators so that they can understand that this isn't something where we're trying to prevent anyone from having the choice of buying what they want, or certainly preventing anyone the ability to build a business from the ground up, which we're very much supportive of. But really, it's about number one, safety, and also more like what is the impact to our agency when we don't have any funding, but yet we need to support the community in these ways. So I don't know if anyone has questions about that, because it's a big one for us right now.
Is the cost of it associated like with us is if there are outbreaks, but like who is surveilling compliance with this?
These are some of the problems.
Yeah. So that's a great question. So the way it's set up is that it's written very vaguely that if you do this, you would need to register with a local public health, regional public health, state public health agency. There's no clear direction. So it's sort of like who's managing an overall database. And then, if there were an outbreak, because there's no really great way to be able to sort of trace that back, people are supposed to label things, but there's no primary registry. So it would be very difficult and time intensive to try to do an outbreak investigation.
Interesting. And to expand this kind of risk at a time when public health is just being cut back is a bit of a struggle for
I'm
us.
assuming there's like no fiscal note, it's just like there's no appropriations that will be.
Well, there is. Do you want to talk
for
about that, Tessa?
CDPHE, so the funding that Governor Polis had recommended for having raw milk expansion, that bill is not moving forward. He's recommending that shift to 1.5 FTE at CDPHE to manage this cottage food expansion. The challenge with that is that people will contact Boulder County Public Health, and we want to respond to them. We want to provide the information. We want to support our community. We don't want to kick them off to the state. And still, they'll also come to us, right? And we provide the best, customer experience we can for our community. So,
and if there's an outbreak, it will fall on us.
Yes. It will. So, the good thing is that I think the testimony Shauna provided was really helpful. We had a legislator reach out to us who wanted more information. So I think, we're really able to be providing a unique perspective in terms of we have the data to talk about what the real impact looks like to public health. So that's been really helpful. And very, just a big thanks to both Carol and Shauna, who spent a lot of time putting this together, and that it's really helpful for us to be able to have a voice in these bills as they're being considered. And then even though the raw milk bill isn't going forward, the House Ag Committee still wanted to hear the impacts of raw milk on public health, which is great news. You know, we are very appreciative that Zach Lusgarten, our food safety lead, and Dr. Belknap, who I hope is still on this call or maybe on this call, our chief medical officer, are both going to be providing some remarks on Thursday. And that really ties into what does an outbreak look like? What does it cost? So it's very much tied into this cottage food conversation, even though it's a little bit adjacent to that directly. Next slide.
Tessa,
Okay.
can I,
Yes.
sorry, I just wanted to say, Carol must still be listening in. She just chatted me that they've already had some investigations related to what she said are parking lot tamales. So,
Oh,
yeah.
Carol.
yeah, so that's because our environmental health team has foodborne illness complaint, reporting and then they respond. And we have had foodborne illness complaints related to like tamales that someone bought in the parking lot, and the environmental health team goes out. We've never struck on an outbreak or anything that way, but I know we've had investigations. And yeah, if it expands, I could see that need to expand additional foodborne illness complaints and potential outbreaks expanding.
Yeah, that's helpful. Thank you, Carol. That's something for us to be able to add in that. So I'll follow up with you on that and add it into what we're communicating with legislators.
And it's difficult because, you know, at the same time, we feel the strain of this kind of a law. We also recognize that it's important for people to be able to make a living. And it's disappointing that we aren't able to find a way to satisfy both of the needs right now.
Yeah, I would just add one more comment that parking lot tamales are often very delicious, and as long as you heat them up to a proper temperature for the right amount of time, they're usually perfectly safe. And I don't want to dissuade anyone from purchasing cottage foods.
Absolutely. Yeah, I think we all want to support the people to purchase those foods and eat them, but there will be an impact, financial impact and resource impact on our agency and other local public health agencies.
Some illness in the community, probably.
So this ties in well to the next topic, which is that there was a figure setting hearing on the state budget. And as you may recall, the current proposal is an ongoing $3.3 million general fund cut to LPHAs. There was already a reduction of $3 million last fiscal year, or for this fiscal year, last June, during the special session. The proposal is an additional $300,000. The vote failed. There was a 3-3 tie, which is, you know, good news for us. Overall, what was interesting about the conversation is that it's a really, really tough budget year, but every single person in having that discussion was really supportive of local public health agencies and talked about how difficult it was to have to cut it. But because they couldn't agree on it, it means that this will be revisited during budget reconciliation, and that will be sort of when there's a lot more information about what the budget looks like. We don't know when that will happen yet. Next slide, please. So we, you know, now that we're engaging more with policy, we have, and I'm registered as a lobbyist, we've gone ahead to register positions on bills that we feel like are particularly important to public health and to our community. And so these are the bills that we have registered that we support. One is treating people with behavioral health disorder. This one was amended. This really talks about the medical transport of people who are experiencing a health crisis or an overdose. And this would sort of streamline those services, and would also have CDPHE be responsible for medical assisted transport and licensing of those vehicles. The next one is the legal protections for the dignity of minors. This one was changed a little bit, well, actually quite a lot. There was two parts to this. This is for transgender youth to be able to seal their previous name, and only access would be given under with consent of that individual. That part of the bill remains. There was another part where family law courts would need to consider a parent's support of a transgender youth's identity in determining a custody schedule. That part was struck because the bill was not going to be able to go forward with that piece. So the rationale for having to take that out is that it would actually change Colorado legal statute. So I think that the bill sponsors are thinking about another way to bring a similar kind of effort forward for the next legislative session.
And these, I just want to be really clear about this bill. It's not just that it's about the dignity of minors. These kinds of decisions have an enormous impact on mental health of LGBTQ youth, on suicidal ideation, on likelihood of attempting suicide, of severe depression. They are directly tied in the evidence base to those issues. And so some of the actions of the federal government over the last year really activated the state of Colorado to move in this space, and we're really proud of that.
Thanks for that additional context, Lexi. Just quickly on the other slide, the mobile home park water quality bill is an expansion on an existing bill, and it really just clarifies that it just expands protections for mobile home park owners and water quality. And then this next one, provider participation in health insurance, is the one that Lexi noted earlier. And what this does is it ensures that it's easier to find an active provider who's both taking new patients, and also that is still active. You know, I think a lot of times people will go to look on their insurance website trying to find a provider, but it's like a ghost. Someone isn't actually actively taking people or doesn't exist anymore. So it's trying to clean that up so that it's easier for people to get healthcare. Okay, so these are some new bills that we're keeping an eye on. One is the Alcohol Impacts and Recovery Enterprises. This would create 3 new enterprises for the state of Colorado, one for spirits, one for wine, one for beer. All of the revenue generated from these would go to funding the behavioral health administration programs that are already in existence. So we're keeping an eye on that. There's also this next one, hospital funding, is actually it's an excise tax on alcohol, and all of the funding from that would go to building a 50 to 70 bed treatment facility in Aurora. The next one, alcohol beverage manufacturer sales, would create the ability for a small alcohol manufacturer to sell products that they have not produced themselves, but that are also considered craft size. It would then necessitate the vendor or the proprietor to also sell food, which would obviously impact our food safety team. So we're keeping an eye on that. We know that CALFA is doing some work and talking to the sponsors about what that would look like. It would be a licensed situation, so there would be funding available to support our food safety team in the event that that passes. The next one is protect. Is there a question?
Nope, you're good.
Okay. Protect food safety of individuals who are immigrants. This one, is just exactly what it says. It's really intended to make sure that immigrants in our community have a lot of protections. It's a very wide-ranging bill. Our BOCC policy team is really on it, but we're also keeping a close eye on it. And we're continuing to monitor the measures to improve Black maternal health equity. And I know we're just a few minutes away, so I'll keep on moving through. The next slide, please. Thank you. Our methamphetamine affected properties efforts to inform those in regulations. We have launched a statewide task force with the Boulder County Housing Authority. It's a very wide tent of individuals who are participating. So we have, everything from housing authorities, public health agencies, people who oversee real estate agents. It's a lot of different folks who are participating. We'll be meeting monthly, and then we're going to have quarterly Boulder County stakeholder meetings.
So this work is focused on working with the State Board of Health as they look at new regulations on meth-affected properties. Based on the learnings that we've gathered over the past couple of years in Boulder County about the impacts on housing, the lack of an evidence-based centered on human harm, and the impact of people who are rejected from housing or ejected from housing due to that policy. There are a lot of kind of unintended consequences with the way that the current regulation is written, and we want to help humanize them a little and put them into a little bit more of a framework of evidence-based policymaking.
Okay, this is the last slide, our local policy update. So we provided input, thanks so much to Rachel Arndt, our environmental health division manager, who led a process of giving feedback to the Boulder Valley Comprehensive Plan. There was a significant review of that. It took a lot of folks. So thanks to everyone who participated. This was really a health and all policies kind of effort. And, it fundamentally changed what was in that overall comprehensive plan. So it was really important. We also had our PHAP, our public health. Can someone help me fill in the blank for me here? Anyway, our fellow, our public health fellow. Sorry.
Associate program.
Thank you so much, Carol. And she did a full analysis of about all of these health and all policies, put together a comprehensive document and shared that with other stakeholders so that they could also use it in their own comprehensive plan reviews. So that was really a heavy lift and a very worthwhile effort. And then we're continuing to build the infrastructure to launch our local policy group in May, which will involve some capacity building, consumer relations management platform that will be rolled out, and just really tapping into the expertise we have within our agency in this area already. So we're excited for that launch in May. And then ongoing, these other local policy efforts, our healthy beverages work in Lafayette and Louisville. They had a meeting today. The Lafayette tobacco licensing is moving forward. They have a very organized effort to be just meeting with local stakeholders, policymakers, and I know that there's going to be a conversation on the Belmont coal ash cleanup tonight. Is that still happening tonight?
I don't think so.
That is not happening tonight. No, I don't think that's happening. Not on the
Thank
agenda
you.
anyway.
Then you will have a more comprehensive update on that at the next Board of Health meeting.
All right.
Thank you.
Thank you, Tessa.
Thanks, Tessa.
So clearly, Tessa's not letting any grass grow under her feet. Hope you feel better too.
Hey, item number 6, director's report.
Any questions? We did some, a little bit of shift of the formatting based on feedback from Lindy and Morgan at our governance and budget meeting. We'll continue to work on trying to shape that report into really giving the board what they need to know in the most effective way. Okay,
Great, thank you.
yeah.
Okay. Item number 7, old and new business.
Then to present.
Done. Okay, and item number 8.
11.
There being no further business, this meeting is adjourned at 7:04. Thank you.
Thank you.
Thank you. Good night, everyone.
Bye, thank you.
These are great.
A little bit of a Merry Christmas.